We're here at the 20th Conference on Retroviruses and Opportunistic Infections, and we're here with Julio Montaner, who is the director of the Center of Excellence in Vancouver, BC. And we really are appreciative of you taking the time yet again to do both a program in Spanish and one in English.
Thank you, friend.
Because it's always bringing us up to date on the treatment as prevention. And if you would kind of take us there.
Well, I think the story is coming around very nicely. As you know, we've been advocating for this kind of program to be implemented widely for quite some time. To my view of the conference, the single most important development was the pre-conference satellite, where the WHO announced that they are truly committed to expanding the eligibility treatment guidelines for the south of the world. I'm going to leave the details for the WHO to discuss, but basically it's what we've been asking all along. Mm-hmm. We're moving towards the 500 guideline, CD4 guideline that is, with even an understanding that outside of that range, people who are at risk of transmission should be probably offered antiretroviral therapy. From my perspective, this is terrific because it's really moving us much closer to a situation where the appropriate use of antiretroviral therapy with a single set of guidelines for the whole of the world will open the door for us to have a real impact on transmission. Speaking of which, in the province of British Columbia, as of about a week ago, we have now the latest data for 2012 that shows that again in 2012 the number of new diagnoses, despite the fact that we're testing more than ever, has gone down again. Mm-hmm. And we're down to approximately 248 new cases diagnosed in the year for what it used to be approximately 900 cases diagnosed per year prior to 1996.
So it's moving in the right direction.
It continues to move in the right direction. Now, let's be clear, we have foci of continued transmission, predominantly young MSM, which is a problem everywhere. And this is not a surprise because they're basically getting infected with HIV before we can get to them with our messaging and services. So that means that from a systems perspective, we need to point down to a much lower age and try to engage with that community much more effectively. But let's be clear also too, if we continue to expand the treatment program, even the young MSM are going to have more difficulty finding HIV-positive individuals. I mean, I'm using the wrong terminology altogether because it's not like they're going to go out looking for it. But if you know what I mean, yeah. So by subtracting HIV donors from the community, we're actually partly addressing that problem. But much more needs to be done. The other area where we in British Columbia have a problem is First Nations. Mm-hmm. Why? Because the culturally competent healthcare is really not widely available to them, and so there is a disconnect there. The services are available, but they're not really accessing them.
They're not accessing it. Yeah.
So there are epidemics of HIV in British Columbia, more so in Manitoba, and seriously so in Saskatchewan. But there are pockets everywhere in the country, and so the message here is that we need to map the epidemic to understand what is going on and take it from there. In the United States, for example, there is a north-south divide with much worse epidemic in the south. There is a white-black divide, and among the black, the youth and the women are particularly affected. So it's important to have that map clear so that we can address the problems. And in that context, we have adapted the cascade of care as a metric that we can use, comprehensive metric that we can use to longitudinally dissect what's happening with every single step of the cascade of care. And so that gives you a visual opportunity to look at each one of the steps and say, well, we have a problem here, this other one is going better, and then create specific strategies to fix that. For example, we had a large number of HIV positive undiagnosed, and so we said we need to address that. How do we do it? Well, normalized screening in healthcare facilities. We did 20,000 additional tests in healthcare facilities for people who had no risk that they recognize or that the clinicians recognize. And upon doing 20,000 tests, which, by the way, when we offered a test, there was a 94% acceptance rate, which is brilliant. After doing the test, we found 5 per 1,000 HIV positives unsuspected. 5 per 1,000 on 20,000 means 100 cases. Now think about it for a moment. I just told you that our HIV new diagnosis went down again to just under 250, despite 100 cases that we found that were not supposed to be found except for this new strategy. So we're really making a huge dent to the HIV positive undiagnosed. And so this is the kind of ingenuity and creativity that we need to bring to bear if we're going to fix the problem.
And how, now you in Vancouver have a similar dichotomy of like Europe, where they have the needle exchanges needed.
Yes.
Is that going forward? Or
absolutely. Despite the fact that the federal government continues to play tough and difficult on this issue, they don't understand the Russians. They're ideologically not predisposed to even have a discussion about it. What I can tell you is that the HIV epidemic among injection drug users in Vancouver is all the way down. Is the biggest success we had, simply because we have opportunities to engage with them on culturally appropriate terms, namely in the context of using drugs in a supportive manner. That doesn't mean that we promote the use of drugs, but what it means is that we use that opportunity to engage on a discussion when you're ready, when you feel like it. If you want to move on to detox or cessation programs or substitution programs, we will help you. But if not, we can, despite you continuing to use drugs, we can still start a discussion about your HIV, your hepatitis C, or whatever. And on that note...
So harm reduction.
Right. And on that note, we have already started the preparatory work to translate the test and treat strategy that has been so successful in HIV to hepatitis C. But that I'm going to tell you next conference.
But we're also talking about test and getting entry into care.
Of course.
So then they can be accessing both all diseases.
Absolutely. I mean, the issue here is not, we need to stop looking at HIV as one problem, and we need to use the lessons learned in HIV to say, how can I use this strategy that has been so effective to address other concerns you may have, hepatitis B, hepatitis C, syphilis, gonorrhea, and whatever else.
And in Africa, sub-Saharan Africa, they look at TB and malaria.
Absolutely,
and HIV.
absolutely.
Yeah. So it is really about the whole person and the health of the person. You can't just say it's only this we're looking at. So you're saying now, where are we going from here? I know you do.
Well, as I said, I mean, we need to do more of the same. We need to do better. We need to identify further what are the various pockets that are underserved. And in order to do that, my team is currently working, and again, you'll have to wait until the next conference for me to be able to share the data because it's too preliminary at the moment, but we're working on a stratified analysis of the cascade of care so that we can just, break it down by gender, by age, by postal code. So using all of that information to, in a granular way, going from the macro to the micro to identify, the cascade of care among this group of people, in this region, in this situation looks different than that cascade of care. So there will not be a one-size-fits-all to fix the cascade of care throughout the province. There will be solutions that will be strictly dependent on the various regions and subsets of people that we're trying to fix. For example, for people who are incarcerated, the solution is going to be different than the ones that are using drugs or young MSM. Urban versus rural, men versus women, young versus old, and First Nations, First Nations in reserve versus First Nations in the urban setting. So each one of those will have to be addressed separately, and we're doing that. And then the next thing is set up the stage to use this framework to address other health concerns of the same individuals. And I think that that's a winner.
It's a done deal. The thing that I'm looking at is, this is mostly in Vancouver.
Correct.
Or
the British Columbia, the province.
Columbia, okay. But this is certainly translational to everywhere else if you can get them to politically accept all of the pieces of it.
Absolutely. I mean, every jurisdiction that has attempted a proactive sort of test and treat campaign, take San Francisco, for example, is reporting wonderful results. Yeah. I mean, test and treat is not going to transform San Francisco into paradise. It's pretty nice as it is, but there will be systemic and fundamental issues that may not be addressed. But test and treat will take us pretty close to transforming what is it used to be a rampant epidemic into something that is fairly well controlled, and then we're going to need targeted action to ensure that the remainder can be addressed. And I don't discount that at the end of the day, we will finish the job when we have a cure and a vaccine. Most likely a cure in the short term, but we cannot afford not to do this.
No. And you know, you have been on this long road, and you're getting better, much better along than you used to, and you're smiling. This is a good sign.
Yeah. You know, I'm very gratified. I mean, I must say, Michel Sidibe, the Executive Director of the United Nations AIDS Program, has been a very strong supporter. President Clinton, Hillary Clinton, President Obama, you know, everybody has ultimately come along. But you know, Michel has really given me the support to be able to speak with one voice regarding the value of treatment and prevention. And you know, we don't want to sell one particular approach to it. No. All we're saying is, the more you test, the more you treat, the faster you do it, the better you do it, the more you sustain it, and the more you support that patient population, the better your outcomes, and at the end of the day, you'll save money.
Thank you so much for your time. I really appreciate the visit.
Thank you.